All right, Musculoskeletal, chapter 21. This should be an easy one. Straight from adults as well. This is going to be very easy information for you to remember. This sounds like a broken leg, right? Smells like broken hip, broken leg, things like that you already know from adults. It's just putting it into kids. So the biggest thing with kids is that they have green stick fractures for a lot of the time. It's going to be a green stick versus a full fracture. If it is a full fracture, it's still going to smell like CMS check, color motion sensitivity. Because at the end of the day, we don't want them putting knitting needles in the cast, playing with it, getting it wet, or having compartment syndrome. So let's get started on this one. Don't own this material under fair use. I'm providing lecture content for only my nursing students using this material. All content within is for educational purposes and not for providing medical advice. So, describing the anatomy and physiology of the musculoskeletal system, you've got to know the growth plate. For pediatrics, it's really important. The growth plate is extremely important in kids. Common disorders, physical assessments, diagnostic tests, things like that you'll need. Hospital care, chronic hospital care, emergency care, trauma, and education that you would provide to a parent. So this will be a quick, easy recording. So anatomy of growing bone, you've got to know about the growth plate. So anatomy and physiology, bones are cartilaginous structures. Because kids are growing and developing, their growth plate are open, sometimes making a diagnosis difficult. At the end of the day, protect premature bones. Make sure that they're not weak. Make sure that they're developing properly because the bones are going to suffer. So on your book in page 513, the anatomy of growing bones. So the anatomy of the growing bone, the epiphysis is going to be the ends of the long bones. The epiphysis is the segment of bone responsible for lengthening during growth. And the periosteum is the sheath covering the bone. So make sure that you better understand that going into peds. Epiphysis is injury to the epiphysis can cause long-term results such as children's bones are different than adult bones. Adult fractures must align perfectly. Kids' bones don't have to align perfectly, but their open growth plates remodel and form new bones to repair the fractured area. So until 16 years of age, at 16 and older, they might not have enough time to remodel it completely. And the biggest risk is for subsequent growth disturbance if the plate gets closed early. So immature skeleton on children, their increased resilience to stress, they have a thicker periosteum, their increased potential to remodel, shorter healing times, and presence of the opening. So bones tend to bow rather than break. On compressive forces, you're going to have a fracture or a buccal fracture. Ligaments and tendons are stronger than young bone. Bone's more likely to be injured than soft tissue. Periosteum is biologically active in children, so this means that it's developing new bone and also supplying blood, so it stabilizes fractures and promotes healing. Some immune properties, because of that immature skeleton, children tend to heal fractures faster than adults. That being good with the immobilization time being shorter. but it can also mean malaligned fragments become solid sooner as well. So you're going to have follow-up visits more frequently in children than adults. A callus might be formed when you're using a cast, and children should avoid contact activities for 2 to 4 weeks once outside the cast. So in your assessment, just having a really good assessment. The assessment's going to include physical examination, history taking, height and weight, diagnostics, as well as laboratory values, motor development evaluation, and family expectations. What do they expect? So inspection, palpation, range of motion, lab tests in table 21.1, CT scans, x-rays, MRIs. Okay, so to determine problems or potential delays. So again, CBC with diff, calcium, phosphate, rheumatoid factor, ESR would be septic arthritis, infection, blood cultures, and some of the diagnostic tests are on table 21.2. So an X-ray, fluoroscopy, CT scan, bone scan, ultrasound, and MRI. Again, usual nursing care. Position the effective extremity. The natural normal position is best. Fractures. So fractures are a little more complicated in children than adults because of maturing bones, cartilage, open growth plates. So buccal fractures are some of the most common, and that's mechanism of injury is a direct fall onto an outstretched arm or hand. So compresses bone at either end of the bone. So a fall onto an outstretched hand describes this type of injury. Occult fractures during the maturation process. So the child refuses to bear weight. Softness in developing bone. That means simple stressors such as jumping from a height and twisting unnaturally can cause injuries to the bone. Place them in a walking boot or a cast. Repeat films in 3 to 4 weeks. Sometimes it's just symptom management. So we won't always cast a bone. So if it is the physical injury, 30% of the time it's going to be a growth plate injury. It can disrupt the growth of the bone, and injured near but at will stimulate bone growth. Fractures, most common, distal radius, clavicle, hand, elbow, radius, and tibia. And then if you can look in your book on page 518, a transverse is straight across. A spiral fracture tends to be child abuse because it's completely sheared in a spiral motion. Oblique means straight across on a diagonal. Green stick, D, is the most common for us. Those are like if you went outside and there was a green bush and you broke the branch isn't going to snap in two. It's going to still be attached on one side but broke on the other. And comminuted is completely shattered. Okay, so just know those. Green stick are more so related to children, and they might have a short arm cast for 4 weeks by a removable splint for another 2. Elbow fractures, They're complex, they're difficult to diagnose. So, tibia fractures, typically when the foot is twisted during a fall, it takes a lot of force to injure the tibia shaft. Toddler fractures, toddlers, if you can think about your toddler fracture, they're learning to walk. It's not notable at the time, but they refuse to bear weight. Examine the hip, thigh, and knee. Injury to the buttocks, the back of the leg, the head, and the neck. Looking for soft tissue injuries. This is going to be a long leg cast for 3 to 4 weeks. Weight bearing is tolerated, and it completely heals in 6 to 8 weeks. 20% of kids are going to have an injury. They're going to have a fracture, but looking for the fracture lines is most important. Femur fracture, typically caused by trauma, falls, recreational sports, and car injuries. So we could always do internal fixation, which would mean plates and screws. Could be external, could be rigid nailing. Traction, so on your book 521, know these tractions. So neurovascular checks, so a spica cast for femur fracture. Turn in position every 2 to 4 hours, prevent sores on the heel and the sacrum. So you can find skin fracture, you can find spica casts. Spica casts, the biggest thing with those are just to be careful because if it's too tight, it could also include the abdomen. Since the cast is up so high, you can actually end up with bowel. So again, know all your types. And then we get into clubfoot. Clubfoot, make sure you know the other name for it as well, because that's what got some people in semester 9 on the test. So clubfoot, males more than females. Bilateral or unilateral. Half of the time it's going to be both. And the calf looks smaller on the limb that's affected. The foot is turned inward. The Achilles tendon is shortened. So non-surgical will use a lot of casting. So they'll keep casting it to move down to a normal. But then if that doesn't work, then we're going to have to mold. Casting material is always plaster because it can be molded, where fiberglass is more rigid. A fiberglass cast, just make sure that you're doing CMS checks, color motion sensitivity. Bow legs, knock knees. Know those definitions. So you'll see all of these. Knock knees is where the knees are knocking together. Bow legs are outward. So just know what bow leg looks like. Internal femoral torsion. So knock knees. Bow legs, you see in the picture on page 525. Just know that that's often seen in kids between 18 and 3 years old. Tiptoeing, in-toeing. So if the legs don't straighten out by 7, they might not. So knock knees you see on page 526 versus bowing. Hip dysplasia we talked about with Pavlik's harness. Know that. Hip dysplasia is that the ball and socket aren't in socket. So we use Pavlik's harness. Bryant's traction, sometimes spica cast. And then leg calf burst disease is a loss of supply to the femoral head. And it often affects boys between 2 and 9, and it's painful. So you'll have no weight bearing. Again, that's in your book on 528. Usually a family history. Whites, Asians, Alaska Natives. Thrombolytic component trauma. So the pain can be sudden, referred to the groin, thigh, knee. Decreased range of motion, hip abduction, and internal rotation. A vascular necrosis is going to be no blood loss to the femoral head. Fracture dislocation might not be evident till 2 years. AVN is 1 to 4 year old. It's insult causing loss of blood supply. Eliminate the pain, restore range of motion. Traction, casting, surgery, bracing. So know your Bryants, know your Bucks. Scoliosis. Scoliosis is going to be huge. Going back to septic arthritis, know that. It's usually streptococcus. So strep A or strep B. Osteomyelitis. And then scoliosis, you can see in your book on 531. We typically do this with gym class. So the school nurse goes down during gym class when everybody's in their swimsuits. You tell the person to put their head down, their arms down to their toes. And you can see in the picture that it's obvious scoliosis. So one spinal curve is higher than the other. Hip dysplasia, spinal curves, that's what you're looking for when you're doing scoliosis checks. So congenital scoliosis would be before 6 months. If it's severe, they're going to have MRIs. They're going to be in turtle shells. So TLSO bracing, again, positional curvature while the child matures. So that's the brace, the TSLO. Just know that. It's a thoracombo sacral orthos. So they're going to have an orthotic device. Remember that there should be a shirt underneath that, just like your Pavlik's harness. So you tell them to bend forward and you look for the rib hump. Juvenile idiopathic arthritis. You're just looking at the S shape. the rib hump. Um, Off and on joint pain, knees, ankles, hips, usually occurs bilaterally. Again, the TSLO brace is in the pictures on page 533. So controlling pain with Aleve, methotrexate, medication with food, preserve function, normal growth and development. Evidence-based treatment options for juvenile idiopathic arthritis would include splints, arthroplasty, NSAIDs, glucosteroids. Again, there's lots of biologics that they use these days. The biggest thing with juvenile idiopathic arthritis is macrophage activation. And then some people did osteogenesis imperfecta for their group project. So this is brittle bone disease. Brittle bone disease is an inherited disorder. Again, sports-related injuries, dislocations, subluxations, tears, contusions, overuse injuries. Always remember your RICE, rest, ice, compression, elevation. Tears, contusions, overuse injuries, especially people who are very athletic. Do your sport right, using proper form, wear shoes and equipment that are well fit. Primarily, overuse is not having the right equipment. Which is the most common bacterial pathogen with osteomyelitis? We said group A, strep, that's strep aureus. Strep A, next most common. So the most common is Staph aureus for osteomyelitis. Staph aureus, then strep. Okay, that's an easy chapter.